Hello, everyone. So my name is Gabriel Artit. I'm a neonatologist at the Montreal Children's Hospital. And today I will be talking about near infrared spectroscopy and congenital heart diseases. I would like to thank the organizer of this symposium on near infrared spectroscopy and the POCUSNEO team who's invited me to speak on this subject. These are my disclosure. Medtronic provided via a competitive research grant, NIRS monitors and centers for a study for which I will be presenting some of the results today preliminary. So the objectives today will be to understand the principles of near-infrared spectroscopy, to review some of the evidence on the use of NIRS in the context of neonatal congenital heart defects, and to describe some of the results of some of the ongoing studies on NIRS. So in the context of the perinatal transition, we know that there are many different elements that are critical that occurs in the first few minutes of life and first few hours of life that involves drop of pulmonary vascular resistance, increase in systemic vascular resistance, and all of this framework of different changes can lead to cardiovascular instability in the context of certain neonatal conditions. So you can think things like congenital heart defects, but also patients with, sepsis or birth asphyxia or acute pulmonary hypertension or prematurity may have disturbances that may occur in the context of this transition that may lead to impaired blood flow to various organs. And the care that we provide in the intensive care really, one of the main goals is to maintain adequate cerebral oxygen perfusion in the setting of this changing physiology and also during some of the pathological conditions. And right now, at the bedside, we do use a lot of different modalities like vital signs monitoring and physical exam and urine output, gas, acidosis, but really there's no ongoing live monitor that is able to provide us information about the perfusion of certain tissues or localized tissues like the brain or the kidney in order to be able to better appreciate how there may be some disturbances of blood flow. And a lot of the techniques that we use, like for example, hypotension or tachycardia, well, they often occur when there's already ongoing end organ damage or hypoperfusion. And so I think that's where potentially NIRS may have some space in the NICU in order to augment the way we monitor. And so what is NIRS? It's near infrared spectroscopy. I'm sure you're going to hear a lot about it today. The goal of NIRS is to provide an estimate of regional tissue oxygenation, and it's basically a surrogate for the perfusion of the tissue that you're measuring. And with the number that you're being provided by whatever monitor you're using and sensor is actually an estimation of what we call the venous weighted percent of saturated hemoglobin. And so we'll see that this value is highly dependent on obviously the amount of oxygen you're providing into the arterial compartment, on the local perfusion, on the metabolic demand, but also sometimes on the type of concentration of hemoglobin, because the amount of hemoglobin will obviously, increase the amount of oxygen transport too. And so what we're trying to derive from this monitor and from these numbers is actually a sense of the degree of perfusion, which is influenced, for example, by cardiac output and by the amount of hemoglobin. And if ever some of these elements are changing in time, they may lead to changes in some of these values that you're going to get on your NIRS monitors. So I'd like to, bring the idea that, vascular compartments are like highways. And we have little cars which are transporting oxygen that we call hemoglobin. And basically when the car comes in front of the brain will extract the oxygen and eventually provide you with what's residual in the venous compartment. Now, if the 4 little spots on the hemoglobin are filled with oxygen, we say that we have an arterial saturation of 100% because it's 4 out of 4. And if you remove 1 molecule of oxygen, you're going to end up in the venous compartment with 75%. And so what can affect this process is multiple. You can have a blockage of the highway. Maybe the highway is a bit too narrowed, so the car is not able to get through, or there's traffic, so there's not enough car getting to the actual highway. Maybe the actual motor of the car or the pump is problematic, making that these cars are coming slower in front of the brain tissue, and the brain is, extracting more oxygen because basically it takes more time for new cars to bring oxygen. Maybe the metabolic demand is causing an issue. So you're having seizure or you're needing more oxygen because you have fever or other types of stressors. Or maybe you are in a situation where the actual hemoglobin has a different property and is not able to release appropriately some of that oxygen, or releases too much of that oxygen, which obviously will influence your venous compartment. And so when you're looking at these values at bedside, also in the context of any kind of patient you see, you have to go through these different elements in order to figure out, well, what is my value really representing? Is my value dropping because I have issue in my cardiac output or the heart function? Am I having issue with the metabolic demand, like mitochondrial dysfunction or seizure or hypoglycemia? Is the vessel causing an issue? So is my car not able to arrive in front of my tissue? So for example, with thrombosis or issue with tones. So for example, CO2 and pH fluctuation, and we know that we may have an impact on CO2 and pH with our ventilation. Well, this may lead to vasodilatation or vasoconstriction in some territories like the brain, and that may influence this value. And finally, the quantity of hemoglobin and the type of hemoglobin, as well as the amount of oxygen that's tied to this hemoglobin in the arterial compartment, will influence this value. And so you can see that if you're starting with a lower saturation overall in your arterial compartment, you may still end up with the same saturation in the venous compartment if you only need one molecule of oxygen. But if you start needing more and more molecules of oxygen, you may fluctuate these values. But remember that it's also a saturation. So here we're only delivering one molecule of oxygen, and you're having an arterial saturation of 88% and a venous saturation of 75%. And here I'm giving two molecules of oxygen, but because I have more cars, I'm delivering more oxygen, but I keep the same saturation. So you have to remember that values of saturation have to be placed into the context of what is expected to be the oxygen delivery to that tissue. So NIRS does inform you on oxygen extraction, and some of these parameters may influence how it is reflected. Now, there's another parameter I want to mention, which is the fractional tissue oxygen extraction. This is basically a factor in which we take into context this relationship between the arterial compartment and the venous saturation compartment. And so it's calculated based on the equation of the saturation in the arterial compartment minus the saturation from the NIRS, so either from a cerebral or somatic or renal, and all of this divided by the arterial compartment. And basically, this gives you a fraction that informs you on the degree of the oxygen extraction, starting from the baseline of what you're sending into your arterial compartment. So if you get an increase in this fractional tissue oxygen extraction, it's because this gap is increasing. So either because this is decreasing, or this is increasing, or a bit of both. And so this could be the reflection that there might be some increasing demand or changing in the amount of delivery that we're providing to the brain. And so we just discussed that there's many physiological factors that may influence the amount of oxygen availability in these different tissues. So you can think of cardiac output and local blood flow and perfusion, but also anatomical variability or clots or disruption in vessel or issue with like vascular integrity. Some of the things that will affect hemoglobin dissociation curve, and some of the underlying structures that may also influence the values that you see on your peripheral evaluation. So for example, if you have a hematoma, or if you have like skin or muscle issues with fasciculation that will consume more oxygen, the blood pH, which will change your constriction, the vascular permeability and the hemoglobin content, the metabolic demand. And what you need to put into context when you're at bedside is all of these different elements and look at the different trends. And that's, I think, one of the other key points is what is the trend of these values relative to all my other vital signs and in the clinical context of my patient. So this is just a nice representation of an animal study where they monitored various tissues with NIRS, one of them being here the brain, one of them being the muscle, the kidney, the gut. And each time you occlude the corresponding artery, you can see that there's a dramatic drop in the corresponding renal or cerebral or gut NIRS values, outlining that a decreased delivery will end up with increased extraction of oxygen locally of whatever residual blood flow there is, with values in the venous compartment that will be very low. And this goes back to normal whenever you deocclude these arteries. And so, again, trends are very important, and you are able to monitor different tissues, and you can see that while you're selectively occluding one artery, the other values are completely staying stable. So the heart of the talk, and that's not just a play of word, is to talk about congenital heart defect. And I think the use of NIRS in the context of pediatric cardiac surgery and cardiac anesthesia has been very well established and has become quite a standard of care. And I think that we know that congenital heart defect patients may have tremendous fluctuations in their cerebral and even other organ perfusion, even in the pre-interventional stage. And it's important that we become more accustomed to what's happening to these patients even before the intervention, because some of the interventions that we will be doing in the NICU or cardiac ICU may be influencing some of these organs. And I think that a lot of things that we're learning from congenital heart defect may be applicable to some of the other population of patients with hemodynamic instabilities. And so, for example, we know that cannula misplacement will lead to catastrophic changes in your cerebral saturation, and monitoring NIRS will allow you to avoid these accidents. That's been published. We know that in coarctation repair during the surgery, while they're cross-clamping, we can see dramatic decline in the renal saturation because there's less blood flow going to the kidney. We also know that during aortic coarctation repair, depending on where you put your clamping, either proximal or distal, you may see that there's going to be a decrease or not a decrease in your cerebral saturation. And it's been shown, at least in the adult world through an RCT, that monitoring cerebral saturation during cardiac bypass will actually help avoiding profound cerebral desaturation and decreases the amount of major organ dysfunction after the operation. And just as a proof of concept, during the OR, one of the studies actually saw a quite nice correlation between what's happening in the internal jugular vein in terms of hemoglobin saturation and what's happening on the cerebral NIRS. This study is really regarding the prognostic value in patients with congenital heart defect. This was 41 neonates undergoing bypass, where they monitored the left and the right cerebral hemispheres with NIRS. And what they found was that, first of all, the right and left were completely corresponding to each other. So that's reassuring. It tells us that we can monitor in a frontal area for some of these neonates. And at values that were extremely low in the perioperative phase, which are values below 45% for cerebral saturation and below 40% for renal saturation, actually correlated with the outcome of mortality or need for ECMO. And the values of extremely low renal saturation was actually associated with a prolonged ICU stay. This other study was specifically regarding hypoplastic left heart syndrome. It was a pretty large cohort. They monitored 48 hours after the first stage operation. And what they found was that significantly higher values of cerebral saturation and renal saturation were actually associated with surviving stage 1 operation. And so when they put it in their logistic models with multiple adjustments of confounders, they found that cerebral saturation and renal saturation was actually early predictors of early mortality and ECMO. This other group actually looked at the question of neurodevelopment. This was a prospective study where their main outcome was looking at mortality or neurodevelopmental adverse outcomes using the Bayley scale. They had 54 patients at follow-up in terms of survivors, and they found that 39 patients of their cohort developed some kind of poor outcomes, so either adverse neurodevelopment or mortality. And these particular patients had a much lower cerebral saturation after surgery. either 60-minute off bypass or 24 hours off bypass. And you can see that the values are in the adverse outcome at least 10-point different, and average in the values below 50% of cerebral saturation, which were associated with these adverse outcomes. Back in my fellowship, we were actually also interested in the single ventricular physiology, but really during the transitional phase. So we looked at our single ventricular population in the first 72 hours of life. So here there were hypoplastic left heart syndrome, and there were tricuspid atresia and pulmonary atresia and intact septum. And these patients have a lot of fluctuations because we maintain their duct open and they get a drop of PVR, and eventually they get a lot of steal effects. And we actually extracted the data from their first 72 hours. And what we found was that their renal saturation dropped dramatically in the first 72 hours, probably reflecting the fact that they had some steal effect. And at the same time, the fractional tissue oxygen extraction of all of these patients increased both for the kidney and the brain, outlining that there was probably more and more need for oxygen extraction in these patients. We also compared them to a population of controls, and we found that the cerebral saturation of the congenital heart defect single ventricle was much lower, as well as the renal saturation, and that their oxygen extraction was much higher as well. And so that was a first insight that even during the transitional physiology, there were clear differences in these patients with congenital heart defect that may actually be reflecting their underlying hemodynamics and potentially maybe explaining why some of these infants are developing brain injury even before they're actually going to surgery. And there's another group that actually reproduced similar results, and they even classified by various type of physiology, cardiac physiology. And so this data is also up to 120 hours, where you can see that there's clear differences by physiologies, with some of the physiology being worse than others. We recently ran a prospective study. This is Carolina Michel-Macias, which was one of our fellow in neonatal hemodynamics. And what she was interested was to look at actually the population of congenital heart defect admitted to our ICU, where we did basically echoes every day and monitored with cerebral saturation and renal saturation up to 1 week of life. And she wanted to see if those patients who actually showcased diastolic steal towards the end of their monitoring had different profile of CSAT or RSAT, telling us that if we're stealing from the systemic circulation, are we causing issues in terms of the profile of their cerebral and renal saturation? And so she wanted to describe the cerebral and renal sat trends in the first week of life of these neonates with various conditions of congenital heart defect. And she wanted to compare them based on the presence or absence of retrograde flow in the aorta on the last echo available during the research monitoring. The hypothesis was that this diastolic steal would lead to adverse cerebral and renal saturation. So it was a prospective study. We enrolled patients that were born more than 34 weeks, but ruled out those that had significant congenital anomalies. And we monitored their NIRS values until the day 7 of life. We went back on their echo and we evaluated if they had retrograde flow during diastole as a marker that there is a steal effect. And we used the last available echo for classifying this. So we ended up with 49 patients included with NIRS monitoring and daily echocardiography, and some of the diagnoses are here, the majority being quartz and transposition of great arteries. These 49 newborns were classified into those with retrograde and non-retrograde flow in the descending aorta, and you can see that about 55% of them had retrograde flow, and they were monitored for about 80 hours in terms of monitoring. So here is the birth weight, which was similar across groups, as well as their gestational age. The raw data is showing here that through time, you can see that the cerebral saturations are dropping, outlining that there is an effect of time where there might be less and less blood flow going to the brain. And because of that, more and more oxygen is being extracted with time. So there might be an effect of performance of these hearts that are more, that are different than the normal cardiac architecture. But the other thing that you can see is that patients with retrograde flow had much lower cerebral saturation compared to those with non-retrograde flow. And this is true also for renal saturation, where you see kind of the same gap and the same trend of going down. When you're looking at their oxygen extraction, you can see that the patient with non-retrograde flow were relatively stable through time, while, both of them were relatively stable through time. Here, there's a bit of a difference, but there's much less patient being included towards the fringe of the values of time values. And we can see that those with retrograde flow had much higher oxygen extraction at the level of the brain compared to those with non-retrograde flow. And this was true when we also placed them into models where we saw that in the brain, retrograde flow was associated with an extreme increase in oxygen extraction by about 8 points. And it was also associated with lower cerebral and lower renal saturation just by the fact of having retrograde flow. These are the values just to see the effective time between the retrograde and non-retrograde flow. You can see the renal saturation are a bit lower in the retrograde compared to the non-retrograde, and they're slightly dropping in time in both groups. We can see the same trends with the mean cerebral saturation. So for us, this study is telling us that in patients with congenital heart defect, and especially neonates before even going for surgery and intervention, having already a steal effect from an imbalance between your PVR and your SVR may impact the amount of oxygenation you'll have at the level of your brain or your kidneys. And this decrease is quite profound in the context of this ductal steal phenomenon, which may explain why some of these patients who have this very precarious physiology may end up with some degree of an organ injury. Pasini Kanaprash is another fellow in our program. This time she took this cohort and she wanted to see if there were correlations between what's happening at the level of the NIRS values and what was happening at the level of the brain ultrasound in terms of blood flow parameters. She felt that her hypothesis was that cerebral saturation and oxygen extraction would be corresponding to some of the Doppler values we get at the same time on ultrasound. And so again, this was a prospective study. We did also head ultrasound Dopplers for the first 7 days while we were monitoring them with NIRS. This is an example of Doppler of the anterior cerebral artery. We chose the ACA because obviously the NIRS probe is on the frontal cortex and the ACA is providing blood flow to the anterior cortex. And we look at the peak systolic velocity, the end diastolic velocity, and the mean velocity. And with that, we place them into the equation to get what we call a resistive index or a pulsatility index. When these indexes are increasing, it tells us that there is more resistance to blood flow. And so this time she had 34 patients for which she had a match between the NIRS values and the head ultrasound values that we did at the bedside. And what she saw is that here in the overall cohort, we have the tissue oxygen extraction and the time since birth, or the cerebral saturation and the time since birth. And you can see that there's a relative increase in time in oxygen extraction, like we previously outlined, and there's a progressive decrease in cerebral saturation. Similarly, you can see that there's a trend towards an increase in pulsatility index, so more resistance to flow, and increase in resistive index with time. And so actually, when we plugged this into the models, we found that there was an association between the resistive pulsatility index and the corresponding NIRS values, outlining that they were going hand in hand into the various patients during their monitoring. So it tells us that, you know, the instantaneous values that we're getting in terms of blood flow parameters of the brain correspond to what we're seeing via the NIRS monitoring. I'll finish quickly with a project that was done by Dr. Marina Mir, who's currently part of the Division of Critical Care Medicine at McMaster University. She was working with me on a project where she recruited 15 participants post-congenital heart disease repair. And what she found was similar results, was that what we found on the ultrasound via transcranial Doppler in terms of resistive index and pulsatility index matched the value that we would get on the NIRS monitors in terms of cerebral sat and oxygen extraction. And so that tells us that there's, the NIRS in this population seems to be reflecting parameters of blood flow to the brain. I'll be speaking quickly about the implementation of NIRS in my own institution. If you scan this QR code, it will bring you to a website, which is the NeoCardioLab.com. And on this website, you will find a lot of resources that are available that we use locally for our own NIRS program. And so I've put there some of the tools, like, for example, the tools that we have for our nursing team regarding what is NIRS and who's eligible in our unit, as well as how do we set up the actual NIRS monitor for our own systems, as well as the guideline that we use locally in terms of skin integrity, manipulation of the monitor, use of the NIRS sensors, and some of the algorithms that we have developed in order to better implement this in our NICU. You will see that there are videos in which we describe the use of NIRS and that we also show how to install the NIRS at the bedside. And you'll find a lot of different resources that are quite interactive and that you can use for your own learning and potentially for your own unit. So the population that we tend to monitor in our unit is the congenital heart defect population for the first 7 days of life. And we also monitor patients with hypoxic ischemic encephalopathy during therapeutic hypothermia and rewarming, as well as patients with medical instability like shock or on inotropes at the request of the medical team. This is the monitor that we use, and this is the algorithm that is attached to our monitor, where the nursing team needs to notify the medical team if the values are less than 50, which are values that have been associated in the literature with potentially more adverse outcomes. And basically, the nursing team evaluates if the sensor placement is okay, and then eventually looks at, is my patient hypoxic to explain this? Is my patient hypotensive or in shock? Is my patient anemic? Is there a risk of cerebral vasoconstriction? Is it a concern of metabolic rate that's altered? Or could there be an underlying other condition like severe ductal steal or hypoperfusion or severe IVH or cardiac failure that may be explaining why these values are very low? You'll find on the website and our protocols different questions and algorithms based on either blood flow decreasing, metabolic demand increasing, oxygen delivery being impaired or artifact. And same thing when values are too high, which may also be a concern because extremes may not be very good in the evaluation of these patients. Quick example, this is a patient with hypoplastic left heart syndrome that we monitored with cerebral and renal saturation. And eventually, this patient actually started developing, This is the case. This is the case that I wanted to showcase. So was monitored and eventually started to develop very low values that were below the 50s. And the team was called and assessed the patient initially and felt that the patient looked within normal limits, but eventually the values keep on dropping. And 3 hours later, the patient developed septic shock. And you can see that as we're doing the management of this patient and providing, resuscitative measures, the values of cerebral sat restart increasing and are brought back to within normal ranges. The other thing is this is the case of a patient who had a suspicion of a coarctation and where the nursing team called the resident where the values started to drop very rapidly. So you can see that the trend went down, eventually re-increased. And this is a patient that was stopped from PGE in order to see if the arch was sufficient for the OR. But overnight, the team decided to restart PGE based on this profile. And eventually, you can see discussed with cardio team. Eventually, no weaning of the PGE was done. And eventually, the second heart echo was performed and confirmed the diagnosis of coarctation of the aorta with severe arch hypoplasia. And actually, this patient was brought to the OR the same day. So I think for me, these are just two quick examples where we use it in our own unit and we see that at the bedside, there are thresholds that are of concern and for which our team are being called. So in conclusion, I think that NIRS may be a valuable tool in monitoring infants at risk of hemodynamic changes, such as infants with congenital heart defect. That cerebral saturation often will reflect the simultaneous ultrasound parameters of blood flow. I hope that I was able to convince you with some of the preliminary data that I was able to show. Trends are important, and if you have absolute values that are changing in front of you, you always need to put them into the context of the overall status of the patient, like any kind of other vital signs. So you need to think about oxygen delivery, vascular territory, and oxygen consumption. And we still need a lot of studies and research in order to establish some of the important thresholds of concerns in some of our neonate population, as well as to evaluate some of the management algorithms. So thank you for inviting me. Thank you for your attention. And I have here my email and my website. And if you have any questions, feel free to ask me or to contact me. Thank you again for the organizing committee for inviting me to this wonderful symposium.